Good afternoon, everyone, and thank you for joining us today for our webinar sharing highlights from our latest domain research, our Analytics Market Trends Report. This webinar will share highlights from our recently released 2017 Analytic Market Trends, looking closely at what's changed in the past year with regards to market dynamics and vendor offerings. Each year, we try to produce a market trends update within about 18 months of our last one. So this is a follow-on to our 2016 version of this report, and a lot has changed, as you'll find in this webinar. You can download the slides from the handout section in your GoToWebinar panel, and feel free to submit questions during the webinar. We will address them at the end. For those of you watching the recording, the link to the slides is in the video description. Our team here at Chilmark Research is united by the belief that effective deployment and use of IT is essential to modernizing care. Understanding the emerging trends and technologies to enable this is what drives our choice of research topics each year. It is our goal to provide objective, forward-thinking insights that will help create an informed market of stakeholders that can truly impact our care delivery system. We look forward to working with you in other capacities throughout the year. Please feel free to reach out after this webinar if you have any questions about the report or about our other research. As with a large portion of our research this year, the contents of this webinar touch upon the growth of payer-provider relationships and new strategies evolving in the industry. The theme of our Convergence Conference this fall will be covering all of this. We hope that many of you will be able to join us. It'll be taking place at the Hyatt Regency in Boston, October 4th through 6th. You can join 250 other senior healthcare executives learning about this and other trends shaping the new healthcare business models tied to these convergence strategies. Industry leaders such as Dr. Sachin Jain from CareMore, Gary Loveman of Aetna, John Bolger from Geisinger, and Paul Black are just a few of the highlights of our speaker lineup. You can find more on the Chilmark Convergence website. We're really excited about the lineup that we've put together. We have some great sponsors that are putting together some special sessions as well, and we'll be continuing to deliver more details about the event as we finalize some of the little remaining pieces that are left. Today's speaker is Brian Murphy, who handles our coverage of interoperability and analytics here at Chilmark Research. He has been with Chilmark Research since 2012 when he came on board to assist with our coverage of the HIE market. He has since stepped into the analytics coverage role as well and wrote last year's Analytic Market Trends Report and is following up with this year's. We're also thrilled to be introducing a new analyst who recently joined our team. He put up a blog post a couple weeks ago as part of us welcoming him, introducing himself to our followers of our blog. And he will also be stepping in to help cover the analytics space, assisting with Brian. So I'll let Ken introduce himself now. We want to take this opportunity to give him a chance to address everyone publicly.
Yeah, thanks, John. And hello, everyone. Yes, I joined Chilmark Research this year. I see that I'm going to have to get another photo taken without my tie on to fit in more effectively. I've been around in IT for coming up on 40 years. More than half has been in the healthcare space. Most recently, I was with the advisory board. I'll be covering analytics, and in particular, a lot of advanced analytics, AI and machine learning, mobility, and a number of other topics. As John just mentioned, I wrote a blog post for our Convergence Conference on the topic of analytics and how it applies. You could make a pretty good case that payers and providers have been at war with each other for decades, and patients are really the collateral damage. But analytics and this convergence trend has the possibility to lead to peace and maybe even prosperity. You think about the kind of information that needs to get exchanged between providers and payers. Even transaction data can be problematic, one side trying to use it against the other in contract negotiations. Health information exchanges have done a great deal in moving information between payers and providers, but they really can't provide the trust that has to occur for true advance. Information that a payer might send to a provider or vice versa, in a response to a request might be just minimal. And there may be some additional information that could have been sent that would have made the other side's job a little bit easier. And I think we have to move towards these trust frameworks and greater cooperation if we're going to be successful. But even folks with the best intentions and the right motivations and trust will still need the best possible tools. And that is, I think, a good segue into the detailed comprehensive report that Brian Murphy is going to discuss now with our 2017 Healthcare Analytics Trends Report. So I'm going to turn it over to Brian, and then I'll be back to take a look at the kind of questions that come in that we'll address near the end of this webinar. So thanks for having me, and on to you, Brian.
Thank you, Ken. So we've got a tremendous amount of material to cover in a fairly short period of time, so I'm not really going to dilly-dally around. This is kind of our agenda. Just to kind of set the stage and explain what this report was about, we've been doing this report for something on the order of 4 or 5 years, and it has focused on the software and the solutions that clinical organizations need to support their early efforts with having a direct responsibility for risk. So these products provide a way for clinical organizations to kind of monitor and report on where they are with respect to care quality and costs in programs such as the Pioneer ACO program, Medicare Shared Savings program, and similar sorts of private payer programs. One of the things that's become very clear in the last year or two is that the linkages between the products that are covered in this report and care management products, which we do in a separate long report, they have strengthened in the sense that providers are using these products that I'm going to be talking about today to identify groups of patients who could benefit from a care management intervention, and by the same token, care management products are being used to help clinical folks do a better job at achieving the sort of the quality, the cost, and the utilization goals that these products kind of bring out. So broadly, these products they're robust at this point. They're general purpose tools, and they target the needs of a particular kind of buyer and a particular kind of user. The idealized buyer would be a physician practice with patients enrolled in an ACO or a similar kind of program, and that kind of buyer certainly does exist. But for many of the vendors in this report, the buyer is actually a hospital or health system that buys this thing, deploys it out to their owned and affiliated physicians around a particular community. The idealized user was essentially a primary care physician managing an ACO panel. But that too that user certainly exists, but there's a whole lot of other people using these kinds of products on a day-to-day basis. So office managers or nurses are often the primary user, and in that context, it's very common for them to kind of log into these applications every morning and feed information to physicians either in a morning huddle or through face sheets or using different means. So this report has profiles on 18 different vendors, most of whom are kind of household names for folks who've been in HIT. Our traditional minimum criteria here was that you had to have at least $1 million worth of analytics revenue and 3 customers live. We know that there are more than 18 vendors out there that meet these criteria, but we think we've covered the prominent ones, and we are always interested in talking to vendors that we may have overlooked this time around. We've also included what we call mini profiles, which are just short treatments on vendors whose technology is different, and they were chosen essentially because they're representative of the kind of leading edge software that you see in the Amazons and the Facebooks of the world. Before we get into the meat of the vendors and products, I just want to touch on some very high-level observations that we can make. First of all, we think these products are maturing. They are in a very different place than they were 3 or 4 years ago. There have been very significant product actions that include, not just functional enhancements, but some fairly serious interface upgrades over the last year or so from a lot of these vendors. These products basically provide a very solid idea of what has happened in their panels, and they are getting a lot better at describing why things are happening in these panels. For the moment, users kind of interact with these products exclusively through reports and dashboards, that can be based on, they can be tailored, based on the role of the user and how deeply they want to explore the data. But an ongoing challenge has always been and continues to be getting people to act based on these reports. So, presenting someone with information about care quality gaps and getting them to close those gaps is not always easy. So, the HCOs understand that these products are helpful, but that behavior change is the real end goal here. We think, and we've always thought, that EHR vendors are in a slightly better position to provide this kind of actionability, in the sense that the information can be presented and is often presented in workflow, in the EHR workflow. But even the major EHR vendors have fairly large populations of users that are, that get these tools through a portal, which kind of puts them on an even footing with the non-EHR type vendors. These products are assembled using commercial RDMS type products, things like SQL Server integration services, whatever the Microsoft procedural SQL is called. But we are beginning to see more advanced kinds of database and development technologies beginning to take hold here. I'll talk about this in just a second, but device type data, patient generated data, data from post-acute venues, the so-called social determinants of health type data is really in a position now where it can begin contributing to these applications. And our sense is that the combination of these new kinds of data is really going to fuel an expanding range of potential applications here. So we think that these applications, the one I'm going to be talking about today, and we have been talking about for a couple of years, they continue to be a revelation for physicians who are not necessarily used to kind of dealing with this sort of information. Payers have been sending similar information to physicians kind of on paper for a long time. This sort of stuff has been ignored, given that the reimbursement wasn't affected, but the introduction of risk-based contracts has really kind of changed that formula, and people are beginning to pay attention. So the bottom line and kind of the overall message that we want to send is that these products have clearly established analytics as kind of a day-to-day tool, and we think that the planets are aligned here to make analytics more pervasive and a more reliable partner for clinicians in ways that go a lot farther than just the reporting applications that we see today. I think most folks have seen a graphic like this or some variant of it. This basically shows how different kinds of questions that analytics can answer compare to each other with respect to the value that answer delivers, kind of on the x-axis, and the complexity of the data on the y-axis. These products began their lives several years ago, focused primarily on describing what has happened on the far left-hand side. Depth of the reporting that we're beginning to see now has really allowed users to understand kind of why things are happening. So we've clearly moved sort of beyond descriptive to diagnostic. They're beginning to predict certain things. The range of things is probably things that are predicted is probably not exactly where it should be, but we think it's clearly reasonable to expect these products to begin to point HCOs to better ways of doing things. It's kind of now one of the problems I have with graphics like this is it's very easy to look at this and see these as like discrete stages. I don't think that's really the right way to read it. The reality is that HCOs need to be good at all of these things, and when they're able to to routinely describe, diagnose, predict, and do some prescriptive analytics, they will be firing on all four cylinders, and they're going to be able to maximize their use of this kind of technology. So there's a bunch of different types of vendors in this report. We break them out here into 4 categories based on a couple of different factors. Several of these vendors fall into more than one category. The EHR vendors, in most cases are, the HCO's most important IT vendor. The HIE vendors have significant experience with dealing with clinical and claims data. We have a payer category here. It's for vendors who are either owned by a payer or have a heritage of selling into payers. And our last category on the right here are the truly independent vendors that are not owned by an EHR vendor or a payer. We feel like they're in a slightly better position to respond to the market generally and probably less beholden to another product category. The vendors in the payer category have more experience dealing with different payers and different claims formats. The other vendors, the EHR vendors and the HIE vendors, have really strong experience working with lots of different EHR brands. But I've got to qualify that observation. I mean, every vendor here in this report can combine these two kinds of data into a longitudinal patient record, that is entirely effective at supporting these applications. One challenging aspect for any vendor, and this translates into difficulty on the part of the buyer in terms of figuring out who they should focus on, is that this is not a one-size-fits-all type of a solution. There's a tremendous variety in the size of the organizations. There's a tremendous variety in the kinds of users, and there's tremendous variety in terms of the combination of technologies that might exist in an existing infrastructure. This slide kind of puts the analytic software that we're talking about here into the wider PHM software context. So the three legs of the PHM stool, analytics, care management, patient engagement, interact with each other in a bunch of different ways, and altogether, the idea is that they're going to contribute to the kind of outcomes that we see in the lower right-hand side here. And that is, after all, the objective. So the analytics software that we're talking about here kind of prepares and standardizes the source data. In this case, it's EHR-derived or paid claims. In almost every case, the vendor puts this data into a data warehouse that makes possible to then segment patients into various and overlapping and complex cohorts based on lots of different criteria. I think we've got them listed here, based on specific health conditions, risk buckets, cost categories, demographics. The list goes on and on. These cohorts can then be analyzed to kind of understand the detailed characteristics of the cohort. They're used as the basis for care management programs that address quality, cost, revenue, care objectives, and increasingly for reasons that are very specific to the HCO or the risk contract in question. I think I've mentioned that the end user deliverable here is it's a set of reports and dashboards. Generally, it's delivered through a portal where the scope of the data that the individual user can kind of look at and drill down to is kind of role-based. Individuals have access to their particular panels. Supervisory users are going to have access to collections of panels. This slide is just meant to illustrate, we think, what is about to happen with respect to the data that's stored in these or the data that's used for these kinds of applications. On the left-hand side, it's this kind of we're primarily dealing with EHR and claims type data. There's a whole range of different data types that are waiting in the wings, ready to contribute. The size of the slices here is not really all that important. We just want to illustrate two ideas. First, that the existing data sources are going to grow. There's going to be more and more venues contributing to this data, other than the kind of hospital and practice-based data that primarily populates these things right now. And there's a range of different data types that are going to be used for applications kind of above and beyond the ones that we're seeing today. This slide shows the kind of general structure of these applications in terms of the way the average end user sees them. There's a set of cost and utilization reports and dashboards. There's a set of quality and care gap dashboards, and there's a bunch of things that sort of work across the whole product. The cost and utilization dashboards show the kind of major categories of medical and prescription spending. The quality and care gaps start with a set of evidence-based quality metrics, and that it's primarily kind of the ACO and the MSSP and HEDIS quality metrics, and it shows performance levels kind of by cohort and by provider. They also will show care gaps, essentially lists of patients that need a particular screening or a particular evaluation that would then contribute to higher performance of the pertinent quality metric. Some aspects of these products kind of work across both the quality and cost domains. Although this is spotty, across different vendors, it is possible, for instance, to risk adjust, total medical costs or pneumovax attainment, for example, a cost and a quality metric. A lot of these come with something it's usually called a hierarchy editor, and it allows the customer to organize its clinicians, assign patients, to particular panels. Every product has some kind of thing that's usually called a population explorer that lets users query their panels using what can only be described as a dazzling variety of filters. There are hundreds in some cases. And then they can use this same sort of query facility to create patient lists or in many cases kind of purpose-built registries. So that's a high-level overview, and let's talk about some of these things more specifically. One of the fundamental aspects of these products, and something that users kind of experience as kind of separate from the reports and dashboards, is this query capability. It's essentially the ability to do some form of free-form exploration of their patients and their panels. Every vendor in this report has some kind of facility like this, and most do a really good job of it. These are used to, either access predefined cohorts, or in many cases, they're used to define new and kind of different cohorts for a lot of different reasons, but primarily for the purposes of care management. As I said, most of the time, this thing is called a population explorer. It does go by different names. The predefined filters let users kind of, as I said, enter queries, get patient lists. They also basically allow users to do fairly deep exploration of their cohorts using drill downs. So you can get a patient list and drill deeper into the information at any point. One of the unusual things they all support is the ability to download a patient list to a file that can then be imported into Excel. This is sort of unusual because pretty much every vendor will also tell you that Excel is dead, and that you really need to be using the new BI tools like Tableau or Click or Power BI, that kind of thing. But in any event, there is some expectation that people are going to be downloading this stuff and using it for their own purposes. Most of these explorers also come with different ways to visualize the data. So, it's very common to provide a timeline view of a particular patient with that shows over time all of the different encounters and hospitalizations that patient may have had. Some of the more unusual or uncommon filters would be things like average length of stay, or procedure type, or episode type. Now, closely related to this population explorer is this idea of predefined and standard registries, and this is probably, just in general, this idea of using registries is probably a little bit less common than the kind of free-form population explorer, but a bunch of vendors do this well, and it does provide a level of standardization across the product set. From the standpoint of cost reporting, the most common metrics are usually medical and prescription spending, and this data is usually provided in a bunch of different ways. It's either like a rolling year total, or a year-to-date total, or say an average per member per month for some specific time periods. One of the more unusual ways of showing this information is that there's one vendor that shows it per member per year, and the explanation is that they think that PMPM is kind of noisy and causes providers to chase ghosts in the data, essentially. That varies so much from month to month, and PMPY tends to kind of even out the oscillations. Now, with utilization reporting, the emphasis is on high-cost encounters, hospitalizations, rehospitalizations, and ED visits. And pretty much every vendor provides these. The vendors that are a little bit ahead of the curve might risk adjust these numbers and establish a benchmark so that providers could see if their utilization numbers were down or up. If maybe is there something going on that might be driving those numbers down or up. One of the more unusual things that people show is there's one vendor that does SNF readmits, another that splits out emergent and non-emergent ED visits. So there are a handful of vendors that are doing kind of more than just hospitalizations, rehospitalizations, and ED visits. Now, most of these products also provide the ability to figure out where else patients are receiving care. So this kind of out-of-network analysis is always, has usually focused on costs, and it's been a good way to understand where revenue leakage might be occurring. So now, one of the more unusual treatments of this topic that we've seen is the ability to distinguish out-of-network activity that is occurring at providers who are seen as competitors as opposed to non-competitors. So that would be, it's out-of-network utilization, but maybe they're getting referrals from that provider, so that's seen as non-competitive. Another unusual feature is kind of the ability to see how out-of-network providers are doing in terms of quality performance. We have kind of positioned that particular capability, which is sort of unusual, as a kind of the first step in a contract modeling process. There's one vendor that has Forward Health has a very unique way of visualizing out-of-network activity, where you can look at a particular patient or a cohort or a provider and then visually see where all the care is taking place and whether it's in or out of network. So the quality and gaps functionality is all based on evidence-based quality metrics, and the most common are the ACO metrics, the HEDIS metrics, and PQRS. And PQRS, is, I'm sure most people are aware, is a pure kind of fee-for-service kind of environment. So this is sort of one example where these things are being used beyond just PHM for beyond just PHM purposes. So, but basically, these reports let physicians see how they're doing, based on these quality standards established by Medicare or private payers, whoever it is. And as this slide indicates, the most common are, as I said, the ACO, the PQRS, and HEDIS. Some of those are the same. I didn't bother to kind of total up the number of different quality metrics supported by these products in the aggregate, but it is literally hundreds and hundreds of them. Almost every single product provides some kind of an explanation of where the metric comes from, how it's defined. Some of the more unusual features we find are a metrics builder, the ability for a clinician to sit down and define and deploy their own quality metric for whatever purposes. This is something that you see in hospital analytics products that work great. It's still relatively rare in this market. Care gaps are based on those quality metrics, and the purpose is to help physicians kind of structure their encounters in a way that kind of lets them maximize their performance on the quality metrics. Now, the last column here refers to is not really related to quality, it is related to coding. So roughly half of the products that we looked at provide some ability to identify the so-called HCC coding gaps. HCOs are reimbursed for Medicare Advantage patients using something called a risk adjustment factor, and essentially physicians have to have kind of one E&M activity for a specified set of conditions every year, and these products will help alert physicians to the need to do those E&M activities. So it's not strictly speaking quality related, but clearly related to revenue. This is an area, this ability to kind of identify and push gaps to physicians, we think we've really only kind of scratched the surface. You know, we've talked about quality care gaps, we've talked about coding care gaps in terms of the HCC. There's a whole range of different things that, you know, analytics could be used for that could ensure that different kinds of things that are easily missed in the day-to-day hustle of the average physician practice, and make sure that patients are just generally not falling through the cracks. And that is what this slide is meant to illustrate. So now in terms of risk, most of these products are very good at providing risk scores and risk adjusting different kinds of metrics based on the characteristics of the cohort in question. Now, a prospective or concurrent risk is a great thing to know. It is primarily, those are essentially financial ideas, so it's not always as meaningful for clinical users as you might think. They, from what we're hearing, they're a little bit more interested in more specific predictions, like understanding the odds on different disease path progressions. Most of these products are good at predicting hospitalizations, rehospitalizations, ED visits. They can give you odds on that. But in the aggregate, that's kind of the extent of the predictions that are on offer here. That said, many of these vendors are leveraging risk scoring in a lot of kind of different contexts and in very creative ways. But we think that there's a real demand for this idea of developing somewhat specific predictions or odds on a variety of different things. So this is an area where we're expecting a lot of activity over the next couple of years, and in particular using things like AI and machine learning. There's a lot more to these offerings than just features and functions, and I know I've been droning on about features and functions. Most of these products are offered on a kind of a software as a service basis. Many of them are hosted in name brand clouds, but these are some of the things that provider organizations talk about when we talk to them about these products. Oftentimes they talk about this stuff more than they talk about features and functions. So it's always important to recognize that kind of IT 101 blocking and tackling is important and is a major consideration for most of these healthcare organizations. So that's kind of sort of our summary of sort of where things are and who's ahead and what some of the kind of leading edge features are. If I could just sort of wrap up in the next couple of slides here, we think that there's I mentioned at the top that there's more and different kinds of data than just EHR and claims data. The data exists. There's a demand for it. Many vendors have begun to experiment with it, and our sense is that the tried and true relational databases are going to need some help. It's not clear that they have the scale, and it is clear that some of the big data options out there are better at handling the kinds of data types we're seeing here than their relational equivalents. We also think that this idea of AI and machine learning, it's really in a position to make a difference here in terms of these applications. There's a lot of talk about social determinants of health, but it's not clear that people really understand, what is the difference between a social determinant of health for a diabetic versus a congestive heart failure. So, trying to figure out that context is something that we really think that AI and machine learning is going to be able to do. Developers interact with these data stores using, what is now ancient relational type APIs. We think there's a lot of room for APIs that are probably more closely tailored to the needs of healthcare applications. For instance, an API that delivers a particular cohort, for example, would be something that a developer could make some use of. So, and that's better than some user building a patient list. If that was programmatically available, we think that there's that would be fuel for better applications. Finally, we think that APIs are also going to help move the industry from interacting with this data strictly through reports and dashboards and making analytics part and parcel of all kinds of different HIT applications. I mean, I think the analytics could certainly contribute to a better EHR experience. There's all kinds of room to apply it in care management applications. So this idea of being able to embed analytics in other applications, we think the time has come. In terms of the applications themselves, I spent a lot of time here talking about the cost applications, the quality applications, care gaps, out-of-network, etc. There's all kinds of different contexts where we think it makes sense to apply this kind of technology and this data, and we've got them listed out here. One of the vendors that we did a mini profile on, they have this ability to compare different care pathways to each other and figure out which delivers a better health outcome. That should be more widely available. It should be more reliable. One of the things that a lot of folks have been talking about for a number of years is trying to figure out how much it costs to do certain things. So, for instance, if you knew how much it cost to drive your Pneumovax numbers from 50% to 80%, you might say, well, fine, let's go ahead and do it. But if the costs were prohibited, then you might want to go back to the payer and say, well, instead of going from 50% to 80%, how about we go from 50% to 65%? So we think, these kinds of reporting applications are great, but unless people really understand what it costs to do things, they're flying blind. Safety analytics is something that has been done for a long time in hospital settings. We think that in a conventional office setting, there's safety-related events occur, and it's there's certainly an opportunity for physicians want to do a better job and they want to do things safely, and we think there's an opportunity to use this technology to kind of find it. Some of these products do a little bit in terms of medications adherence, but there's diet. Patients walk out their door with dietary instructions or exercise instructions, and there's really no way to figure out whether patients are adhering to that kind of stuff. So if you believe that social determinants of health are going to contribute, this would be one way for that to occur. Care transition analytics, there's all kinds of transitions that there's all kinds of problems with transitions, and we think that applications that really exploit this sort of cross-venue data could certainly make sure that referrals happen, make sure that referrals are effective. So there's plenty of opportunity there. Contract modeling, I think I kind of touched on when we were talking about out-of-network utilization, but this, the ability to figure out which physicians should be part of your organization, which patients, how those physicians might perform with your panels, could go a long way towards HCOs being able to negotiate better contracts with payers. So these are some of the things, and I got to say, if you kind of look down this list, there is, of the 18 vendors that we profiled, at least one of them is, every one of these is being talked about by at least one, and in some cases more than one. So to wrap up, we think that this set of applications has laid a foundation and set an expectation on the part of physicians and offices out in communities, in clinics, and in satellite offices of big systems, places where this stuff has not traditionally been popular. It's set an expectation that these applications can provide value. But I do think that these are sort of pioneer applications, and there's, the stage has been set to use these things more broadly. We are, we're doing a solid job of descriptive. We're beginning to do a solid job of predictive. There's clearly lots of room for growth there. And some of the most, the biggest healthcare systems are having some success doing, truly prescriptive kinds of analytics. And where the expectation is that, as I said at the outset, of those 4 different categories, we think that every HCO needs to be doing them all. We think, I think you can make a case. First 2 are in really good shape. The third is showing promise, and the fourth, is just over the horizon. And finally, when we talk to provider organizations, we think that they are open to solutions from different vendor types, and in particular, the largest organizations, it's not uncommon for them to buy multiple solutions. The opportunity for differentiation based on kind of price, functionality, the kinds of customization, how much time is needed before results are achieved, the services that are wrapped around innovation, these are all factors, and we think it's the brand that the solution carries does not entirely carry the day. So I think that brings us to the end. So Ken, are you still there?
Yes, I am, and our attendees are also. In fact, we got a load of questions.
Okay.
How many of them we can get through. So thanks for all that information and analysis. The first question is a bit of a general one in terms of which applications are showing the most value with analytics. And the person asked the question was asking, well, for example, going towards meeting government regulation and reporting requirements, or possibly going after risk contracts. So have you seen one particular type of application, higher end of interest, and some that are not as popular, and what might be behind that?
Yeah, I think that's a complicated question because I think we talked about the different kinds of organizations. I do think the heritage of some of these applications, or a lot of them really are about examining costs. So relatively speaking, if you just want to kind of just based on the sort of number of screens and number of metrics that you see in these applications, they tend to focus more on medical and pharma costs. And certainly there is a very strong, people absolutely need to do their PQRS reporting, and they absolutely need to do their ACO reporting. So I think the sort of cost reporting is, I think it's really heavily used, but in the end, in terms and value, values in the eye of the beholder, these sort of population explorer type of offerings, I think ultimately are going to be in a better position to deliver value from the standpoint that they're going to help people get very specific about who should and shouldn't be in a particular cohort in terms of delivering a better health outcome. The ability to distinguish between patients who adhere and don't adhere, and treating them differently from a clinical standpoint. To me, that is from a value standpoint, I think there's a lot more there necessarily than just meeting a government reporting requirement. That's really important because it that determines how much you get paid, but the motivations for a lot of these buyers is really about patients.
All right, thanks. A question about point of care versus more retrospective, read a report after the fact. Are there any particular use cases that you see as particularly amenable to this, that when vendors were giving you examples of where they succeeded with point of care, what kind of applications were those? And so, did any of the vendors show that, or only a handful?
Well, in general, it's really only a handful. Now, I think I alluded to this. The EHR vendors, in some respects, have an inside track, in that they are able. So when a physician walks into an exam room and there's a patient sitting there, and they open the patient's chart, the EHR vendor can, doesn't mean that they always do, but can present all of the care gaps for that patient, which gives the physician the opportunity to act on that and do whatever they need to do to close those care gaps. Those same EHR vendors will tell you that that doesn't necessarily always happen. These applications are more about behavior change than the technology, or so there's still the challenge for the organizations is really to get the physicians and other clinicians who can really act on these to get with the program, and that works better in some places than others. Every one of these vendors talks at length about this topic, and it is an important part of their implementation process with with their customers. Doing the kind of training and proselytizing needed to get people on board.
All right, thanks. Well, I'm not surprised that someone pushed back a bit about that question regarding relational databases, and maybe not to the task. Would you like to elaborate?
Yeah. So it's look, the relational databases are 30 years old, and they do. I mean, they are undeniably workhorses, and they are mainstream. They are 99.9% of the products that we're talking about right here. The tool, developers know them. The tools are there. They are manageable. They provide a level of reliability that is unquestionable. However, there is a revolution occurring outside of healthcare, really outside of enterprise computing, with respect to database. And I think that healthcare needs to pay attention to there's lots of different ways big data is done, and it's clearly not for everybody. And I think this kind of technology is going to is going to have an effect here sooner rather than later.
Yeah. Well, that led to another question regarding vendors with experience outside of healthcare stepping into healthcare, and are they at an advantage? Do you see some of the leaders coming in from cross-industry experience and now entering this market, or most of the leaders companies that have been in healthcare for a long time? Most of the time when vendors from outside of healthcare, healthcare, it's big, it's crazily inefficient. There's the problems are just everywhere, and they seem simple, and these efforts invariably end in tears. It's difficult to see somebody wandering into healthcare and moving the needle in some significant way. But that said, where I live, within like a mile or two of me, there used to be 3 Sears. Now there's 1, and there's 20 Amazon trucks driving around the neighborhood. So yeah, I suppose anything is possible. Yeah. On a similar note, have you seen any influence from international vendors that may have deployed solutions in Europe, for example? Someone was asking about comparative effectiveness and marginal value analytics. They've had some success with that in Europe, trying to bring some of these approaches to the U.S. or U.S. vendors.
Well, I do think that's a great question. We're pretty inward-facing here in the United States. The relatively few of these vendors have significant international businesses. Some certainly do. We didn't really look at what people are doing. I mean, comparative effectiveness is a crying need, and if somebody's doing a good job of it outside the United States, we know about it, and I'm ashamed that I don't know about it.
Well, someone did comment that you were right on with how database technology is advancing, and we got to get beyond just relational. You know, one thing that we saw with the EHR market was the vendors had focused on either the ambulatory or the acute, or some were managing to do both. And even in the acute space, there were those aimed at the community hospitals, the mid-size, or the very largest academic medical centers. Has analytics taken a similar development path, or are most of these vendors really going across the whole continuum of care? That's their value equation, and they're going to adapt their solution in some fashion for who the particular buyer is, but they didn't really start aiming at just, for example, ambulatory care or the largest health system.
You know, it does seem to me that the predominant buyer, or at least the buyer with you know, with the biggest deals in this market, is kind of hospital and health systems, and we hear more about the large end than you know, the community hospitals and the, you know, small and rural. There are a number of these vendors that have fairly large numbers of big practice customers, so it does seem like the buyer here is clustered at the either, you know, the big end of the practice market, or to some extent the big end of the hospital market. The kind of, given that at least in this initial round of value-based payments and the requirement, what the payers, private and government, are requiring is sort of uniform across these sort of different environments. So from that standpoint, it doesn't seem like it's, you know, that we're getting the kind of fractions that you see in the EHR market, but it's, you know, that could happen.
All right, last question. Let's see, we're crossing the top of the hour here. For the folks who are going to be working with you to look at the report in more detail, the rankings and the ratings and so forth, were there any capabilities that were particularly contentious or difficult to ascertain when you were doing these evaluations that you could speak to?
Yeah, I mean, we, you know, so for those of you who are familiar with the way we kind of rate these companies, I would say that the most contentious category was in this whole idea of population exploration. I think that the capabilities are to some extent kind of all over the place, and we tried to establish a rating system that, first of all, covered the whole market. You know, that we could reasonably say, you know, who was sort of at the introductory level and who was at the sort of more advanced level. But the gradations are so fine that it was difficult, and we did get quite a bit of pushback from different vendors. We'll try, you know, we will try to do a better job in the future. But I'm happy with the results as they stand.
I think you're being humble there.
Yes.
Okay. Just in looking at the clock, I'm going to John to come back and help wrap us up.
Thanks.
So these slides and the webinar recording will be posted in the next few days. I will send out a follow-up email with all that information and the details. And you can purchase this report on our website. If you haven't gone and checked out the new revamped Chilmark Research website, please do. It is a completely new user experience, and we're really happy with it. We think it'll be a lot better for all of you as our visitors. But yeah, we will keep you posted about the conference and all the follow-on items related to this webinar. Thank you for attending, and thank you for submitting all of your questions today.